Okay, so thank you so much for joining, everyone. I will just share my screen. Okay, hopefully everyone can see that. So welcome to our STPN monthly webinar, and this month we are doing the management of severe asthma. So just a little bit of context there as to why we've decided to do this topic. And we're hoping that the following 2 hours are going to be helpful for you all and informative. So we are planning to cover and explore treatment of asthma, including the discussions around use of Hi Flo. We're going to have some perspectives from General Paediatrics as well as PICU, medications management, including use of infusions in asthma, and considerations for intubation and ventilation, as well as possible complications that are associated with asthma. And that's going to lead into a talk about guidance around chest drains. So we've just got some resources there that I can also share at the end. So we've just got the Resus Council Paediatric Emergency Drug Chart, as well as the link to the STRS PICU Tools app, and that's our Moodle in the bottom left there. So we've got 2 QR codes, so feel free to have a scan of those. But as I said, I can share those again at the end and in chat as well. So I'm just going to stop sharing there. And our first speaker is going to be Paul Seddon from Brighton. So Paul, I wonder if you want to have a go at sharing your screen again. That worked fine before, so that should be okay.
Do that, yeah. So share my screen.
Thank you.
Can you see that okay?
Yeah, we can see that fine, Paul. Thanks so much. I'll let you take over now.
Okay, that's good. I will, if I do that to go to slideshow, yeah, is that still showing okay?
Yeah, that's perfect.
Just makes
Thanks,
them
Paul.
a little bit bigger. Okay, that's great. So yes, welcome everybody. Thanks for joining. So I'm going to start with a disclaimer. I've been asked to present the results of the Hi Flo study, but just to stress that this is a feasibility study. So you shouldn't be taking any conclusions about effectiveness or not of Hi Flo from this. We plan to go on to a definitive study, but hopefully it'll be useful in terms of a background and also some lessons about clinical research and how to get involved. So we're talking about Hi Flo, highly humidified nasal cannula oxygen therapy, which we've abbreviated to Hi Flo, but it's also sometimes abbreviated as HFNC. And of course, people often use the trade names of things like Optiflow or Vapotherm. So it's a variable mix of air and oxygen, anywhere between air and 100%, delivered at more than a litre a minute, usually a lot more than a litre a minute, heated to body temperature, humidified to 100%, and delivered via short, fine nasal cannulae. That's to say, they're not snugly fitting like the nasal prongs of CPAP. There's leak around them. 2 main commercial versions, Optiflow and stroke Airvo, the Fisher-Paykel version, and Vapotherm, the US version. Both are used in this country, although the Fisher-Paykel is a lot more prevalent. So how does it work in theory? How is it claimed to work? Well, certainly humidifying inspired gases is a very good idea. It prevents mucosal damage and reduces the metabolic work that children use to humidify gases. Another important thing is washing out the nasopharyngeal dead space. So young children have a very large nasopharyngeal dead space compared to adults. And by washing the carbon dioxide out of that, you reduce the tidal volumes you require, which reduces the work of breathing. As you go down the respiratory tract, these postulated benefits get a little bit more speculative. So it almost certainly does reduce work against upper airway resistance because the flow delivered is much greater than inspiratory flow, and because there is some degree of positive pressure which can cause some splinting of the upper airway to stop collapse. And then this is a little bit more dubious in children beyond the neonatal period. There probably is some positive pressure to the lower airways and alveoli, which helps to maintain patency of small airways and improve VQ mismatch. That's more difficult to demonstrate once you get beyond neonates. So you will all have had experience of using this and be aware that it's become quite widely used in paediatrics, starting off in neonates, moving on into bronchiolitis and pneumonia. It's been used post-extubation, and for a variety of airway problems, and creeping into use in acute asthma and wheeze. It's popular because it's perceived as non-invasive, it's quite well tolerated and relatively easy to use, and generally pretty safe. There are some isolated case reports of air leak, but these predominantly when people have used extremely high flows and or inappropriately tight-fitting cannulae. But it would be fair to say that the evidence base supporting its use is still weak in quite a lot of areas, including in acute asthma. So it's a promising technology that's well tolerated by children. It's popular with healthcare staff. It's generally safe. Perhaps the main risk that people worry about is over-reliance, in other words, not moving on to more definitive airway support. Still finding its exact place in respiratory support, but the first ABC study, which was relatively recently published, looked at children with a range of respiratory problems that were felt clinically to require respiratory support. So I'm just going to admit somebody who's trying to get in, who's in the lobby there. In first ABC study, children who were clinically felt to require respiratory support were randomized to either high flow or CPAP, and high flow was found to be non-inferior in that setting. In acute asthma and preschool wheeze, the evidence is weak, but it's creeping into practice. There are some small studies that have been published as rescue therapy, which have been promising. And let's just, there we go. If you look at the BTS sign guidelines, there's pretty good guidance right through to first line management with high dose inhaled bronchodilators. But once you get beyond that, in other words, to children that haven't responded to first line burst therapy, there's no clear guidance. You can use IV magnesium, salbutamol, aminophylline. There's a range of management in different places. Obviously, that's going to be discussed later on in the meeting today. If high flow is effective in acute asthma, it's likely to be most effective early on. And there is now portable equipment available. I'm not sure if you can see it on to the right of the screen there. This is the Vapotherm portable equipment, which we used in the high flow study because it was the only portable equipment that was available at that time. Okay, So the study that we carried out was, the official title was Early High Flow Humidified Oxygen and Acute Severe Asthma. The problem we were looking at was acute severe asthma in children aged 2 to 11 years, and we defined that as severe wheeze not responding to burst therapy, but children weren't required to have a prior diagnosis of asthma, otherwise we would have excluded most of the preschool children. The intervention was high flow, highly humidified nasal cannula oxygen, commenced within 4 hours of starting burst therapy. And the study was a feasibility study funded by the RFPB scheme. We targeted originally 70 children across 4 sites. And the underlying hypothesis is, can early high flow improve outcome in acute severe asthma? But the aim of this study was, can a full randomized controlled trial of high flow be conducted safely and successfully? Here's the study outline. So eligible children were identified in the emergency department. They were randomized. At this point, they were said to be enrolled to either standard care or to high flow, in other words, starting high flow as the next step. Because this was an emergency department study, we didn't take consent before randomizing children or before starting the interventions, but we did approach parents later for consent. And at that point, if consent was given, they were said to be recruited, and we followed them through to discharge and collected data on outcomes. So just briefly about the deferred consent model, it's widely used now in studies of acute illness because, to be honest, if you're looking at emergency conditions, it's simply not feasible to do a randomized study using traditional consent. So what we did was to put out lots of posters and leaflets to inform families that the study was going on. If the child was eligible for the study, they were enrolled in the emergency department, randomized to one of the 2 arms, and then they were approached, usually the next day when the child was stable, by a research nurse normally, with full information to seek consent. So the screen shows an example of the posters we had up and also some leaflets that were available. Inclusion criteria: 2 to 11 years, acute severe asthma, as we've said, and failure to respond to burst therapy. So burst, at least 2 doses of salbutamol doses within an hour, normally 3, with or without ipratropium, and failed to respond we defined as having a PRAM score of 5 or more between 1 and 4 hours after the salbutamol dose. If you're not familiar with the PRAM score, and it's not widely used in the UK, it's basically scored on 5 different aspects. You add the score up, but a PRAM score of 5 or more essentially is a child who's still got significant respiratory distress, usually with mild to at least mild desaturation. Exclusion criteria: so we wanted to exclude children who really had bacterial pneumonia, so high temperature with focal clinical signs. Obviously excluded children who had impending respiratory failure, in other words, the ones who looked as though they needed intubation pretty much straight away. Children with a contraindication to high flow, and other major respiratory, cardiovascular or neurological conditions, or obviously children who'd previously been recruited to the study. So if children met all the inclusion criteria, no exclusion criteria, and were signed off as meeting those, then we had an online randomization using a program called Sealed Envelope, which was available on the emergency department desktop, and then they either went to standard care, so that was at clinical discretion. So normally the next step up in that group would be an intravenous bronchodilator, but it wasn't mandated, or to start high flow with those numbers. I think you see there 2 litres per kilo per minute, then adding on an extra half a litre for every kilogram above 10. The primary outcomes were treatment failure needing escalation, and the escalations could be starting an intravenous bronchodilator, starting high flow in the standard care group, or needing some form of respiratory support. Second candidate primary outcome was time to meeting discharge criteria, which we defined as being able to maintain oxygen saturation above 92% without oxygen and able to go 4 hours without bronchodilator doses. And there were some other candidate outcomes, secondary outcomes that were included, which I won't go through in detail. So presenting briefly the results. So as I said, this was a feasibility study. So I'm going to first of all present the feasibility data, which are the most important, and I'll talk a little bit about the outcomes, but again, to remind you, this wasn't a definitive study. So the first thing to say is that recruitment was not as straightforward as we'd originally hoped. You can see that there was a 15-month pause in recruitment. I'm sure you can all remember what happened in around March of 2020, which was when COVID hit the UK. We had to pause recruitment for the study and then gradually reopen. At that point, we'd only opened one site, the Brighton site. We'd started to recruit very well, had to pause for 15 months. Then it took a long time. There was a backlog of other studies that were given priority to open. So we didn't actually open the other 2 more sites until October 22. And then the fourth site, so we added on a 4th site in December 22. And as you can see, there was then pretty steady recruitment. Our original target was 70, but when we looked at the deferred consent rate, it was actually much better, much higher than we anticipated it might be. So with the permission of the Trial Steering Committee, we reduced the target to 50. So these were the feasibility outcomes. We were looking for at least a 50% enrolment rate among children that were eligible, and at least a 70% deferred consent rate, and at least 80% data collection complete per participant. And then confirmation from the data we collected that we could do a study of the size we needed with a number of centres and recruitment rates to allow a definitive trial to be conducted over 3 years in the UK. So objective 1, at least 50% enrolment rate. We weren't able to collect this outcome in all children at all sites, but for sample periods, when we looked at the data, we were enrolling about 50% of eligible children, which was actually surprisingly good, considering many were arriving out of hours. Objective 2, at least a 70% deferred consent rate. So 56 children were enrolled and randomised. Of those, 50 families gave deferred consent. That's 89%. 44 of those were face-to-face in hospital. If they went home, and this especially happened over the weekend, without being approached for deferred consent, it was much more difficult. So six were successfully tracked down after discharge by telephone contact. There was no consent received from 6 families. In only one case did the family actually decline to give consent, and there were particular social issues there. In the other 5, we couldn't get a deferred consent because we couldn't contact the families after discharge, or we could contact them and they said, yes, we'll send back the consent form, but never got around to doing it. We had some end of study questionnaires and interviews, which basically showed that families felt that they were happy with the deferred consent model for the study. But the other thing that we learned from that was that many of them didn't remember having seen all these posters and leaflets that we put up in the emergency department. Data collection. So both the 2 candidate primary outcomes, we had complete data collection. For the various other ones, that was pretty complete. There was only one that was less than 80%, which was time to ability to maintain oxygen without support. We also looked at what proportion of children were actually given their allocated treatment, and this was a bit of an issue. So not surprisingly, if they were allocated to standard care, all of them received standard care. The ones allocated to Hi Flo, a significant minority didn't actually get to receive Hi Flo, and in a lot of cases that was because there was no HDU bed available, or in a few that Hi Flo wasn't tolerated. So if we look at the candidate primary outcomes, treatment failure needing escalation of therapy, this was 64% of children in the Hi Flo arm needed some kind of escalation of therapy, and 86% in the standard care arm. What were those first escalations? Well, as you might expect, in the majority of cases, it was starting an IV drug. That was the most common. Interestingly, in the standard care group, 3 children were escalated fairly early on to Hi Flo, which again wasn't ideal in terms of keeping the 2 arms separate, but we weren't, obviously in an emergency situation you can't mandate what clinicians decide to do. And also interestingly, when we looked at what IV drug was given, in 90% of cases it was a magnesium bolus, and that's been a change in practice really over the last 10 years. From salbutamol was the most common back in 2015, now clearly magnesium, and that's come out from other surveys as well. Time to meeting discharge criteria. So we were hoping that time to meeting discharge criteria would be less variable than actually time to actually going home, and it was a bit less variable, and there was a slight trend to go to meeting discharge criteria earlier in the Hi Flo group. But as you can see from these graphs there, the red is standard care, the blue is Hi Flo. There was really not a clear separation between the 2. So although there's the median was slightly shorter, there was quite a range in both of them. So to conclude, and I hope I've kept to time reasonably well, despite challenges due to the COVID epidemic, the study recruited steadily and closed on target. Our results suggest that a definitive trial of early Hi Flo in acute severe asthma is feasible. The deferred consent model is appropriate for acute asthma randomized controlled trials and seems to be acceptable to families, but capacity issues for providing Hi Flo need to be addressed, for example, by training staff in non-HDU ward areas. Our feeling is that things have moved on a bit since we started recruiting for this study, and there is more confidence in using Hi Flo in general paediatric wards. So briefly, next steps and learning points. We're in the process of applying for funding to conduct a full randomized controlled trial. The primary outcome, we're going to make it more specific, need for escalation to IV therapy. We will need to randomize 258 children to achieve 218 with deferred consent. We're being a little bit more cautious and saying 85% deferred consent rate. So that's 109 per arm. That would be feasible with the recruitment rates that we showed in the feasibility study, with 9 sites over 30 months. Changes we've made, the PRAM scoring we've decided wouldn't be feasible in a larger study. So we're going to use routine parameters from the new National Pews score to recruit children into the study. Sites need to be able to deliver Hi Flo on the general wards, otherwise during the winter months when HDUs are busy, we'll find it very difficult to recruit and to give allocated treatment. More specific outcomes, as I say, escalation to IV therapy. Age range is extended up to 16 years. We're going to be using Airvo 3 rather than Vapotherm because sites generally are more familiar with Fisher-Paykel equipment. And we're looking at other ways to inform families, such as videos, that the study is happening in their unit. So I'll stop there. I will stop sharing. And I think there's a little bit of time for questions. Is that right?
Yeah, fantastic. Thanks so much, Paul. That was a really interesting talk. Yeah, we're doing well for time actually so far, which is always good. So yeah, I think we've got around 10 minutes. If anyone has any questions at all for Paul, feel free to either pop them in chat or come off mute, pop your hand up on Teams, whichever you prefer.
While we're waiting for any questions, just to say that it's very likely that we're, I mean, we've started looking for sites, hoping that we will get funding for the full study. And some of the sites who've responded appropriately have been within the South Thames area. So if this study runs, it's quite likely, as I think is it predominantly trainees that are on the webinar, or a mixture? Anyway, if you are a trainee in South Thames region, it's quite possible that you will be at a site that are running the study, and it's actually an opportunity. There's now an associate PI scheme where, if you're interested in getting involved in clinical research as a trainee, if your site is running that study, you can ask to be an associate principal investigator, which is quite good, both in terms of research experience and your CV. So think about it.
Thanks, Paul. That's exciting and really good for everyone to know as well. So yeah, if anyone's got any questions at all, feel free to ask. Dr. Kader?
Hi, Paul. Yeah, quick one. So you mentioned about sort of using OptiFlow in a general pediatric ward.
Yes.
Have you actually achieved it? I mean, because in lots of places, DGHs, if a child needs escalation, and we do sort of use sort of OptiFlow at Surrey, then they are generally sort of, in terms of nursing, requirements and things, they are just kept in the HDU bay. We don't have a proper HDU per se, but we do have bays close to nursing station things. So,
Yes.
so just wanted your sort of, the recommendation on what basis. And yes, you're right. If you really need to get more into the recruitment, then probably, if you just put that as a sort of a parameter in various hospitals, you just give only if you have the HDU capacity. How are you sort of going to address
so
that?
I suppose there are two aspects to that. We're obviously ideally looking to recruit sites that are, quite a lot of sites are already administering Hi Flo on their general pediatric wards, often as a step down. So, for example, and you're probably aware of the Bach B study that's going on in bronchiolitis using Hi Flo humidified oxygen, and as part of that'll be running over the next year or so. So that probably will increase the amount of experience in using it. But we're also, if we have sites which are perhaps just starting to use Hi Flo outside the HDU area, we will have some training available during setup from so the companies have undertaken to provide additional training. But you're quite right, there is an issue whether you call it an HDU area or not. Obviously, there is the importance. It's important that nurses are confident to look after a child who's on Hi Flo humidified oxygen. I'd say in general, the amount of comfort with it is increasing. but there probably is still some way to go, and that's probably appropriate because it's, you know, as I say, it's still a technology that has a relative lack of evidence behind it.
Mm-hmm. Yeah, fine. Yeah. No, we have been using it for bronchiolitis and probably asthma as well for a while. But then you know, when you keep criteria and randomize and sort of say after a burst therapy, if they don't, and then you're going to sort of, you know, have 50-50 in terms of going to the next step. That's where the difficulty comes.
It is, that's right. And I mean, what was happening during the feasibility study certainly in one of the sites, in our own site in Brighton, we only looked after children on Hi Flo in the HDU. So if a child was randomized to Hi Flo and they were concerned that there was a lack of HDU beds, sometimes it just wasn't being started because people were concerned they wouldn't have a bed to. So I think that is going to be really important for the because clearly in the main study we don't want to have a lot of children who are randomized to the intervention and then don't receive it.
But again, given the sheer numbers in winter and things, I don't think you'll have, even with the current practice, I would have thought that if more centers sort of, you know, come in, then you would definitely be able to achieve. That's what I thought. But just putting it as a, you know, giving it in a sort of a general, yeah, I use it more often without the appropriate nursing. What is it? You know, requirement. That's what I wanted to clarify. Yeah, that's fine.
Yes,
Thank you.
yeah, no. People, I mean, sites have got to be confident that that they can use it clinically. That's right.
Okay.
Okay.
Doesn't
Thank
look
you
like
very
there's
much.
any more questions, but thank you so much, Paul. Thanks. Okay, great. So our next speaker is going to be Jatinder, giving a general paediatrician view on managing severe asthma in DGH. Oh, I can see you, Jatinder. You've just popped up on my screen. Hello.
Hi there. Hi. Hello, everybody.
Have you got some slides to share?
Yes, let me do that. Right. Okay, hopefully you can see that.
Yep, can see that.
Okay, I'm going to minimize the MS Teams, and then I won't be able to see if there's any hands up, but I'm happy to kind of pause in between if to answer any questions if needed. Okay.
Okay.
All right, thank you. All right, hello, welcome everybody. Thank you for joining us this afternoon on our asthma webinar. So my name's Jatinder. I'm one of the paediatricians over at Down Valley Hospital. I'm also one of the STPN clinical leads for paediatric critical care. And I'll be kind of talking from a DGH perspective. And then after me will be Nick, who's one of our other clinical leads for paediatric critical care. And he'll be talking about asthma, status asthmaticus from a PICU perspective and when it starts to get really complicated. So please do kind of feel free to kind of jump in and ask any questions. Happy to make it as interactive as you like. Okay. All right. So hopefully I can. Okay. So, well, what comes first? Before I think we talk about acute asthma in the DGH setting, something that actually I think as colleagues, we're all very good at looking after children with asthma, and I think it's sometimes the really complicated ones that's where we kind of shout for help, and those that need further escalation of treatment and need to go to an intensive care unit. That's where it really kind of gets quite complicated. But I think before we talk about acute asthma and DGH setting, it's really important that we talk about, from a DGH perspective, chronic asthma and how we kind of prevent exacerbations. And I hope to kind of just set the scene a little bit about that. So asthma mortality, well, UK sadly has one of the highest prevalence of emergency admissions and death rates for childhood asthma. This graph you can see here is taken from a global burden of disease study, last accessed. This was done in 2019, but the study was 2016. And this was a picture, as you can see, I took from another presentation on asthma, but you can see very clearly where UK sits, and you've got so many other countries that are have got lower mortality rates than we do, and there's a number of kind of reasons for that. I'll think just to make it very real. The reality of asthma kills, and this is a child who had passed away a few years ago, but the coroner's regulation 28 report was published just recently, December 28, with an intention to prevent future deaths in asthma. But the sad truth is that there's been a number of reports to prevent future deaths in asthma, but we're still way away from achieving that. And it's not really just a single approach. We need a multi-pronged approach on how to reduce asthma deaths. But this was sadly William Gray, who had a life-threatening asthma attack in October 2020, went to his local hospital, to their A&E, and he initially was not commenced on inhaled corticosteroids and discharged from A&E, or as far as I'm aware, and the report showed that from primary care services. GP subsequently treated him with 3 courses of oral steroids over the next kind of 7 months of recurrent exacerbations. But on the 4 days after the 4th course of oral steroids and no inhaled corticosteroids, he passed away in May 2021, so 7 months after his first life-threatening asthma attack. And that regulation report came out to prevent future deaths. And I apologize in advance if this is a case that occurred in your local hospital. But the truth of it is we've got very similar cases in all our hospitals across the country. And it is just another sad example of asthma and how life-threatening it is. So the risk factors of asthma death, sadly, they've been known for quite a long period of time. We've known it for decades. Excessive use of short-acting beta agonists, i.e. salbutamol, is life-threatening. That came out of the NRAD review and 2019 global initiatives on asthma. We know that insufficient inhaled corticosteroid usage is associated with asthma attacks and deaths. The NRAD, they recommended that anyone having 2 asthma attacks in a year should be referred to asthma specialists, and the confidential inquiry demonstrated that more than 2/3 of those who died from asthma between February 2012 and January 2013 had major preventable features, and that was the NRAD study that was done in 2014, so 10 years ago. The major preventable risk factors, that they do keep recurring. Asthma attacks are all too often treated as if they were single acute episodes with no real kind of long-term consequences and no real joined up care to recognize the patient in the middle of it presenting with recurrent presentations, both exacerbations and ongoing symptoms. And it was felt that there was a total failure to not this case, but in our management of asthma, to recognize risks posed by repeat acute episodes. And often these children seen in A&E, we refer back to GP, but we don't think actually this life-threatening exacerbation or this was severe enough exacerbation, they came in a few months ago. We don't look at it from that perspective and think actually maybe I will start and then on an inhaled corticosteroid and then ask GP to review and follow that up. And that's perhaps something we should be getting better at doing, whether we're seeing them in our pediatric A&Es, whether we're seeing them in our pediatric assessment units or short stay units, or onto our children's wards or young person's wards. Acute asthma is often treated as if it's a short-lived inconvenience, i.e. it's not a red flag when a child presents with asthma that their chronic disease is out of control. So as I said, we just treat the symptoms, what we see, treat the wheeze, the 3 days or 4 days or 5 days of steroids or a stat dose of dexamethasone, and then we send them home thereafter because they've ticked the box and weaned to 3 to 4 hours, not required oxygen, and look a bit better in themselves. But we don't see that actually that presentation is a red flag, that their asthma control is poor, they're having exacerbations, and really that's what we need to tackle. We know that at least nearly 10% of the UK population, or 1 in 10 children in a class, you could say, this is the whole UK population, but also in children as well, have asthma. Annually, we have 6.3 million primary care consultations and 93,000 hospital inpatient episodes across adult and children, and 1,800 intensive care unit episodes. So it's clearly a significant condition and lots needs to be done about it. So the NRAD was done in 2014, and we're now, as I said, 10 years on from that. And the feeling is that things have improved, but there are significant changes that have not occurred. There was expose a very simple fact after 10 years that, again, most asthma deaths are avoidable. It highlighted structural systemic problems of delayed assessment, diagnosis, and treatment of asthma leads to unsafe levels of healthcare provision and inadequate support for people with asthma and their carers to appropriately manage their condition. And there are a number of kind of evidence-based recommendations that were made from the 2024 review to improve care. 2014 review to improve care, and in the 10 years since that review initially was published, we know that asthma deaths have increased by almost 25%, and 4 people still die from an asthma attack every day, yet 2/3 of asthma deaths are avoidable with better basic care. And then the 2024 survey of over 12,000 people found that the rates of basic asthma care have stagnated, with only a third of people, less than a third of people with asthma receiving all the elements of good basic care. And I think that's one thing that I just really want to kind of emphasize before we start thinking about how do you treat that child that comes in with severe asthma. It's not just that presentation, it's what else is going on for them. This is a red flag, as you saw in the previous slide, for a chronic disease that we need to get better grip of. So great progress has been made over the years, however. So the NHS Long-Term Plan 2019 has a focus as respiratory as one of the clinical priority areas. Biologics and Pheno were chosen as rapid uptake products in the Accelerated Access Collaborative. And so following that quick uptake, there were widespread Pheno usage. And I believe initially when the 2014 NRED was done, there was only 1 biologic in use, and now we've got 6+ biologics in use. The NHS England created a national bundle for children and young people with asthma, which was clinician-focused resources to deliver high-quality care within the ICSs. Standardized guidance, this is something that's on its way. This is being developed kind of from now onwards, and that's a combined consultation of NICE, BTS and SIGN guidelines, because the reality is there's lots of varying guidelines, and it leads to confusion of what's the best way to go. There's no unified message, so hopefully when that standardized guidance does get published, that would help clarify things. There's also a push towards, especially the older children, the young people, to use MART or SMART regimes, which are regimes where you've got your combined reliever and preventer inhaler within one to reduce your symptoms and exacerbations. And then there's also just recently a bill that came out, which is the Tobacco and Vapes Bill, which essentially says that it will make it illegal to sell tobacco vaping products to anyone that's born after January 2009. So that means anyone from over the age of 15 will not be able to buy tobacco products going forward to create a smoke-free generation. And then the national audit in asthma 2023, which took over previous audits, is an ongoing national audit to improve care and outcomes in asthma. So what are the essentials in asthma? So basic asthma care, that's something that's a priority for all children coming in at acute settings, and that is to ensure they've got good inhaler technique, they've got personalized asthma action plan, and at least annual asthma reviews. And this is, again, something that needs to be done kind of collaboratively in primary and secondary care to prevent these children then coming into secondary care and deteriorating further to tertiary care and sadly death if they have severe deterioration. It recognised that you need designated leads and teams, a strong workforce around asthma management. And I think that's more the case for children and paediatric asthma, because actually there is lots of work done in adult asthma, but sometimes it's not always translated into best practice for children. And we'll see children being given devices that they are not actually able to use, but would be more possible and feasible to do in adults. And so we need to kind of have designated leads and teams at all levels there. Those that have very severe asthma, they need better access to biologics going forward. And so I think from our perspective, secondary care perspective, it's really important that these young people, where they've got severe asthma, are referred early to tertiary service, tertiary respiratory, to really see actually would they benefit from a biologic sooner than we already think of. Follow-up care. So 10% of cases that were studied by NRAD had died within 28 days of being treated in hospital, which is actually a very high number when you think about it. It's really essential that there's early follow-up to ensure that adequate recovery has occurred. And there was a recent study by University of Birmingham that identified that only 18% received follow-up with their GPs within 48 hours of their discharge, following discharge, and only 60% received a follow-up appointment within 28 days, i.e. 40% did not. Next is to do with our patient records and prescribing. So we know that overuse of your SABAs, your ventilating salbutamol, is associated with poor symptom control, and its evidence suggests that SABA overuse is associated with increased risk of exacerbations and death. If we had better data and sharing, we would be able to alert ourselves better to excessive SABA use. But I think we are getting into an age where electronic prescribing and electronic records, where you can see GP records, is more feasible. And I would urge colleagues to, when you have got these facilities available and you've got a complicated a child present with asthma, and thinking about them in your outpatient settings or in your ward settings, to really think that, can you access their GP records or highlight to the GP to review how much they are receiving in terms of their SABAs, and are they using more than they should be. And that's really important part of asthma reviews, is not only are they collecting too many SABAs, but are they, if they are on a preventer, are they collecting less than they should be, indicating kind of poor compliance and adherence to their treatment. We know that their smoking has an ongoing impact, including passive exposure, and this is more prevalent in a deprived community. So again, all children coming to our outpatient setting and young people should be kind of educated, and families educated on smoking and vaping, which is on the rise at the moment for our youngsters as well, adolescents presenting. And then care in non-medical settings. So asthma deaths in schools rose between 2012 and 2022. A study showed by more than 33%, which is quite significant. And so NHS England, CYP transformation program, developed resources for schools, but we need to have that widespread awareness of children not only in the hospital setting, but their school settings as well, and education of their the teachers that are giving them their inhalers, and not necessarily escalating as appropriately as they should be. Again, from secondary care and even tertiary care, this isn't something we can immediately manage, but I think this is important to be aware of, and so that we can, as clinicians and teams looking after children with asthma, start thinking about how do we engage with our community to improve asthma control. So that's the chronic really part of when we talk about asthma, and the things to kind of really be aware and to remember. I'll very briefly talk about status asthmaticus. We have this, which we've all kind of seen variations of this before. This from BTS 2019, as I said, that when the new guidelines come out, which are the shared kind of guideline between the key guidelines, we'll be able to update again with that. But there is recommendation of children should be triaged kind of within the 15 minutes and assessed their level of severity. And that is based on mild, moderate, severe, or life-threatening. And there's various factors which will be able to guide you of where they fit in this. And this is an example. There's lots of kind of variations of this, and different flow charts and algorithms and integrated care pathways that can be used in asthma as well. And I'm sure you'll all have similar in your local hospitals. So mild to moderate, severe, life-threatening, saturations, their use of salbutamol before presentation, signs of respiratory distress, their Pew score. Now, of course, this Pew score will vary depending on your local Pew scores that you're using, and soon we should be able to, with encouragement, move to kind of national Pews and all speak the same language of when we say Pews and what that means. But this will be relevant in your own settings. Peak flow, I think we very rarely do peak flow in the acute care setting in in A&E, but I think this is something that is a tool we can use, not only actually at the point of children coming in, but also at the point of discharge, to make sure that that bronchoconstriction that is present has been improved significantly enough to get them home safely. Their ability to speak and their breathlessness to speak, their GCS, and then their vital kind of signs, their heart rates and respiratory rates. These are kind of key things in assessing their levels of severity. And it's based on that level of severity that you will then subsequently go on to your treatment. And again, this is an example taken from our hospital at Down Valley Hospital, but there's many, I'm sure you've all got standardized approaches to managing acute asthma. Please kind of follow what you use. And if you don't have anything in your current settings, then it's worthwhile having some focus and on making a guideline that will kind of guide your teams to managing acute asthma. But the reality of this is mild, moderate, severe to life-threatening. Most often in a non kind of severe or non-certainly non-life-threatening, where there's no oxygen requirement, you can use inhalers. The key thing with the management of asthma is ensuring that you review these children, reassess them. Are they responding? Is their clinical condition improving, or are they deteriorating? And that's that close watching, constant reassessment, which will be pivotal to that. Someone who's very unwell with low oxygen saturations or severe asthma, we're following our EPALS or APLS protocols of calling for help, giving oxygen, getting access, doing all these key interventions as part of your a thorough A2E assessment. But once you've kind of got through that and you're now assessing them, the majority of children can be especially that you think, actually, I might be able to get this one home, they're not too bad, are people who we can use inhalers with as well. And it again gives you the opportunity to really reinforce good inhaler technique. And there's many times where I've used that in A&E and gone through it with families, and even though they've been taking salbutamol at home and that's led to the deterioration not working, coming into A&E, we often see that their technique is quite poor and their compliance and medication. Again, it goes back to that education, which is really, really important to empower families, carers, and young people, children, to help manage their asthma better and recognize when their control is poor. And that goes back to the basic care I mentioned in asthma. So reassessment is key. Often we will say that if you are kind of 3-ish plus hours with not requiring any inhalers, no oxygen requirement, and stable, that's somebody who can potentially go home. Again, checking inhaler technique. If you've got hospital at home teams, you can use them as well. And it's really key that you've got your follow-up within 48 hours with the GP. And I know that can be a challenge, but it's something that is recommended to see that these children are adequately recovering. Those that are presenting with exacerbation, recurrent exacerbation, they must be started on preventer treatment. And families really need to understand what it is about the preventer and why it makes a difference, and why it will take a while to work, and why you can't miss the just occasional dose, because that will kind of deteriorate their asthma control. Those that are severe, we start thinking about burst therapy, and there's variations of how you do this. And you see some centers that would do kind of Atrovent, salbutamol, nebulizers, followed by 2 further salbutamols, or others that will do salbutamol, Atrovent, and do that 3 times 20 minutes apart. There's no set rule of how you do your burst therapy. I think the key thing is making sure that we're constantly reassessing, making sure that they are improving, and if they're not, then escalating the treatment. And the management of asthma is, essentially as BTS guidelines is. If you can use inhalers, use inhalers. It's very important that we give these children steroids, ideally within an hour of their presentation, so that that helps to kind of have that anti-inflammatory effect sooner rather than later. Some centers using dexamethasone, which is usually a 1 stat dose, can be repeated later if needed as well. And if subsequently not improving with that, then would need to go on to a prednisolone course. But there's variations in what you will practice, but depending on your local kind of asthma respiratory leads. Of course, life-threatening is a child who we're very, very worried about, had the signs as in red that we saw previously. This is where we need very kind of senior review of these children. making sure that we are monitoring them closely, that we are giving them their bronchodilators, and we're considering them for intravenous bronchodilators if there's ongoing deterioration, and aware that if they were to deteriorate further, that their care would require escalation further to that, potentially non-invasive support, and could lead down to intubation ventilation. And it's really important to have that trajectory in your mind very clear, so that you can assess these children from point of presentation to their constant reassessments, that are they deteriorating, and escalate again that early. Of course, we've got our retrieval service, Southern retrieval service. Children that are very unwell, that's a call that's made to a retrieval service. And if you're not too sure and think actually they're pretty bad, but they might turn the corner, that's someone that you can actually still call and get advice for, or give forewarning that we've got this asthmatic child who's very unwell, we are concerned, and ensuring that you've got your local teams involved early, so your consultants, your nursing charges, and your anaesthetic teams to review them, so that should they deteriorate, that you are ready to stabilize them quickly. The STRS guidelines that I kind of mentioned, it kind of summarizes that as per BTS guideline, maintaining oxygen saturations, inhalers, which can be repeated if severe or oxygen requirement, life-threatening, requiring nebulizers, steroids, getting them in early, using hydrocortisone intravenously if oral not tolerated. And often I think we'll find that the very severe asthmatics will be a lot quicker to give them intravenous hydrocortisone. And I don't think that's a bad thing. We will need intravenous bronchodilators if they've got worsening clinical status, and this is our kind of second line treatment. Again, there are variations to this, and again, BTS guidelines also mention nebulized magnesium sulfate as well. And when we think about which bronchodilators intravenously we're going to use, again, you've got to go by your local guidelines. STRS guideline here, kind of first line is magnesium sulfate. I think it can be very effective. You can use a second dose if they have good response. They can have usually just a mild hypotension, usually not clinically that significant, and just need a blood pressure monitoring, but may require a small 10 mils per kilo fluid bolus with that as well. But it's usually, in my experience, quite well tolerated, including second doses. Then your intravenous bronchodilator beyond there, if requiring it, is you're going to give them a loading dose followed by an infusion if there's ongoing concerns. And I think you will choose which agent you use based again on your local protocol. And I think if you've got signs already of salbutamol toxicity, a child that's having already had lots of salbutamol at home, or had multiple nebulizers and reburst therapy done in A&E, or then again done on the ward, and you've got signs of salbutamol toxicity, tachycardia, lactic acidosis, or your lactate going high, tachypnea as well, then that can be someone who you think actually we're not going to give them salbutamol infusion, but going to go for aminophylline instead. We know that as your lactic kind of acidosis worsens, that can worsen your respiratory function as well as you try to blow off that acidosis. So actually it can contribute and make your assessment of that respiratory distress harder. So really being aware of toxicity of salbutamol in these young people, and knowing early when to call it that actually this is someone who is deteriorating and we need to escalate their care, rather than just really kind of overloading them unnecessarily with bronchodilators. It's really important that we consider differential diagnoses of children presenting wheeze and breathlessness. X-rays can be very helpful to identify if you've got any other kind of significant complication like pneumothoraces, significant consolidation. But in clinical history and examination, you may have other features which lead to diagnoses as well. So bronchiolitis, for example, under 2 years of age, preceding cough, cold, cries or history, diffuse crackles, wheeze and auscultation. Often it's the wheeze doesn't just come from bronchodilation. And we know from our learnings from bronchiolitis that often with nebulizers used here, we're usually treating ourselves rather than the patient. But there's a multi kind of factorial reason why they are wheezing, working hard, not just because of bronchoconstriction, but also that mucosal edema and mucus plugging, which leads to that wheeze and reduced air entry. So it's really kind of important not to over cook these children with your bronchodilators. I don't think it's unreasonable, as we saw in recent years, some older children presenting with bronchiolitis, older infants presenting with bronchiolitis with quite a predominant wheeze pattern that actually did have some response to bronchodilation. But it's important to be aware, is it just the bronchodilator, i.e. salbutamol atropine, that made that difference, or was it the wetness of the neb, i.e. just a saline neb? So my own practice, if I hear lots of wheeze and the child's significant distress, is I will think about, do I need oxygen? Do I need high flow? Do I need CPAP? Do I need to escalate? But if I'm at a stage that I think actually medically I could optimize things, I sometimes will give them a saline nebulizer as opposed to hypertonic saline nebulizer, and just see, does that shift their secretions? Does that improve things for them? If it doesn't, I'll stop there. The worst thing to do is, give them a whole load of bronchodilator and then just put it on the drug chart and just keep regularly giving it when no one's actually assessing and reassessing these children. I think we know what the evidence is, but we still have to take that pragmatic approach to the child that's in front of you. And that's where the constant reassessment is really important. Episodic viral wheezes. So these are children where there is limited evidence for oral steroids, and it can be difficult to unpick that episodic viral wheeze from your child that's really presenting with asthma. Again, seek senior support, but there'll be other things in the picture that you might find, atopy, symptoms at rest, coughing at night, and in between. So interval symptoms can highlight to you that this might be something more that's going on with this child, other than just the occasional viral wheeze that doesn't necessarily need steroids. Atypical pneumonias, so both viral bacterial pneumonias with significant consolidation on x-rays. Important to be aware of anaphylaxis of the children presenting with wheeze. And also aware of the fact that nebulized adrenaline or intramuscular adrenaline can also make a difference in bronchodilation, improve things as well. It doesn't always indicate there's anaphylaxis, but being aware of that being a treatment as well, and not kind of thinking that it must have been anaphylaxis that caused it and not actually their asthma, because they responded to the adrenaline. Adrenaline has that bronchodilator effect as well. Cardiac failure, so children in failure can wheeze as well as another differential. Again, your chest x-ray and your clinical examination will help you to do understand what your differentials are here. And then foreign bodies, so previously well child who's short history, witnessed choking episodes, asymmetrical air trapping on chest x-ray, although x-rays can be normal. Again, having that high index of suspicion that could this be a foreign body inhalation that is causing their symptoms. So hopefully your management of the child with asthma was effective, and we've thought about we're thinking about their discharge home, and these are some of the kind of key things taken from our local guidelines, but there's a key kind of key practice that should be applied wherever we're seeing these children, so in your hospitals as well. So we should give them written management plans given to them and discussed and explained how to escalate the salbutamol in acute exacerbation, ensuring that they're only giving it when the child is symptomatic, and avoiding the weaning regimes of which has very kind of limited evidence around of giving 10 puffs every 4 hours and 8 puffs every 4 hours and 6 puffs every 6 hours and bringing it down. I think evidence suggests that does not give actually is more dangerous, does not give the parents and carers the opportunity to treat exacerbations, and can lead to overuse and missing deterioration, which can be life-threatening. So avoiding these weaning regimes that we used to use so commonly. After discharge, if the child is still requiring salbutamol, they must be reviewed 48 hours after the discharge, and it's really important to get this GP appointment within 48 hours for that, to make sure they're recovering adequately. But I think it's probably important that to say to families that if you cannot get that appointment, or it doesn't occur and you're still worried about your child, come back to us. The last thing we want is this child deteriorating further and presenting in a much worse condition. And then you've got your escalation plans. This is just an example of again, ours and other centres that use very kind of similar to this, of how you escalate it further, but essentially using salbutamol puffs, reviewing it, assessing it, get your GP reviews. If it still doesn't work and all your 10 puffs don't last the 4 hours that they should do, or there's significant work of breathing, calling 999 and getting assessed urgently. And these are some of the key messages to take home for these families. What are the key national audit standards? So it's important that we give steroids within the hour from arrival, check the inhaler techniques before discharge, given the personalized asthma action plans before the discharge, refer for smoking, secondhand smoking, cessation, vaping, even in the young person or in carers, and ensuring that they've got appropriate follow-up, ideally within 4 weeks, if this is a child who is representing either severe exacerbation or life-threatening exacerbation, that they do go home on inhaled corticosteroids and preventive therapy and know how to use it, and that they receive GP reviews within that 48 hours. And so that's the kind of a DGH or pediatrician's perspective of asthma and the management of asthma, preventing that deterioration. And then that takes us on to my colleague Nick, who will take you more through what to do for those children who deteriorate. But I'm happy to pause there, take some questions before then handing over to Nick. Thank you.
I'll see if I can share my screen successfully while you're taking any questions.
But if anyone does have a question, feel free to pop a hand up, or also we can also do them at the end if you do think of something that you wanted to ask Jatinder, or both Jatinder and Nick. We can always do that after Nick's talk as well, or after Nadir's talk at the end.
Yeah, that sounds good. Can you see my slides moving there? If I move it there.
I can see your first slide. Yeah, I can see it moving. Perfect. Yeah.
Super. All right, I'm going to join a second time on a different computer so I can see what's going on. Lovely, nice to see you all. I'm Nick Prince, one of the PICU consultants at St George's. Also, Jatinder, his co-lead for STPN critical care on the medical side with Jatinder. Nice to see you all. All right, I do want this to be, if we can, a little bit interactive. So I'll put some uncomfortable pauses in when I want people to speak, if that's okay. So please do unmute and speak. Some of my team's in the seminar room on PICU, so worst case, they'll have to stump up and say something. Otherwise, I'll be after them. These are the things we'll look at. So we're going to think about the sicker child and navigating them through anaesthesia and intubation for asthma. So we'll think about physiology, the interventions we can do, medications, anaesthesia, intubation, and obviously what can happen during and after that. All right, so let's base it around the case. Imagine this is any child you've seen. It's the X-ray of a slightly older child, so a sort of young teenager with a known history of asthma, has had previous exacerbations before. They may or may not have been to ITU, intubated before, and on this occasion, let's say they've had a cough and a cold, not been feeling very well at school, have sort of become increasingly short of breath, and have kind of worked through the home cycle of escalating nebulizers along the lines of what Jatinder was talking about, and then actually comes into hospital and works through the kind of immediate hospital management. So they've had burst therapy, they've had steroids, the team have tried some magnesium. All of those things may or may not have helped a little bit for a while. But let's imagine this young person is looking tired, working very hard with their breathing. Chest is either very wheezy or heading towards the quiet side. And let's say for the sake of it, you did a gas and it is becoming to lean more towards acidosis. So a moderate asthmatic, as you know, should have a slightly alkalotic gas, shouldn't it? Overbreathing, CO2 is low. And when it normalizes and certainly goes up, that's a sign of decompensation or tiring, deterioration. And, maybe your SAT's now at 88% on 15 litres via a mask. So, question to the crowd then. So what's happening with this child? And ultimately, what are our big decision options at this point? So they're on a face mask, they're struggling, and there's plenty of evidence that they're doing less well rather than better, having gone through all the standard management. This is the uncomfortable silence where someone has to say something.
Do you question if the child needs some high flow, perhaps?
Okay, so let's say that's an option, high flow, and we heard a bit about high flow already. Okay, so that's one option. Yep. What else?
Recognize that this is just going to sort of life-threatening situation, especially if he's not talking and is very weak. Yeah, he might stop
Yep,
breathing.
fair. So that's
anytime.
kind of human factors, recognizing the situation you're in, and probably verbalizing that out loud to make sure that the whole of your team understand your train of thought.
And contacting your sort of anesthetist, I guess, priority. So at any time, you need to escalate, then at least the team is ready and it needs an assessment.
Yep, absolutely. So corralling your team, working out who's around, and actually probably beginning to assemble your team based on what you're going to decide to do. So again, just that question again, what are our decisions to make? So Optiflow is one option.
If magnesium sulfate was not given before, time to give one.
Yeah, and if it did work, you could give another dose, couldn't you? But
Yeah,
let's assume we've done
needed,
everything
yeah.
that Jatinder's talked about and the child is in this condition. And things like if you hadn't started IVs, you could. Yep, go ahead.
Adrenaline?
Ooh, adrenaline. That actually doesn't tend to be on, it's a very beta agonist drug, isn't it? But we tend to go for beta 2 selective agents. So you should probably have given lots of inhaled salbutamol, say. If you haven't already, you should try IV. And we'll come on and talk a little bit more about that. So you've got the options of IV salbutamol or aminophylline, and we'll come back to that. But I suppose your big decisions at this point, if you truly have done all of that, is between some sort of non-invasive support, if you really think there's some merit to that, versus actually making the decision to intubate. And then someone just tell me, what is the pathophysiology for this child in this position? What's actually going on?
Trapping and
say again. I think two of you are going to say something. Go on, say it again.
Yeah. And there's significant air trapping on the X-ray. He's getting really tired, so probably his respiratory drive and in a way he can. He's actually compensating to that extent that decompensating to that extent that he might crash anytime. Yeah, so it is.
Yeah, so lots of air trapping, very hyper expanded. And actually, if you look, there's those kind of high, low and lower down sort of streaky changes. So no obvious big focal pneumonia, but actually what this child has going on is obviously bronchospasm. That's what asthma is. And then all of the inflammatory sequelae as well. So particularly thick, viscid mucus production. And actually, you've probably got at this point, for this child, potentially irreversible on their own plugging of their kind of their airways, essentially. So thick, inflamed, bronchospastic, but also full of mucus, and that's often the end kind of pathway prior to intubation. A lot of your treatments are obviously focused on reducing the inflammation, trying to stop mucus production. Ideally, the patient needs to sort of cough it out, and when they can improve. But you may end up in a kind of irreversible heading towards intubation, and there's not really much you can do about it. And if you've given all the medicines and it hasn't got them into a better situation reliably, then that may well be the writing on the wall. You do have the option of things like Optiflow and non-invasive pressure ventilation. We'll talk a little bit more about that at the end. I think what I would say about that is if you go back kind of 5 or 10 years, it was an absolute no. People thought that was a terrible idea. Increasingly, we do get some children through on our unit who are sort of not disastrously bad, but struggling, and we will get a few through. But I think the caution with non-invasive is not to push these children way beyond what they can cope with. Not to fool ourselves, we're making them better with non-invasive. And actually, when you do come to anaesthetize them and intubate them, you've actually pushed them even further down the line of unstable, risky, decompensated physiology. And this is just a nice little graph just to remind you where in our airways most of the resistance sits. And actually it is the kind of large and mid-sized airways. And they're mostly the airways which are getting inflamed and blocked up in asthma. All right, asthma medical management, really you've covered there with Jatinder and we've talked about it. Physiotherapy can be a mainstay of getting out the sort of mucus plugs, but in reality that can be very difficult without them being intubated, and really you just need a child who you can loosen up the secretions, open up their airways, and they can cough it out fundamentally. So again, once they've got to the point that they can't, then really you need to look at other options. And I think for the purposes of safety today, we'll talk about progressing to intubation rather than getting in too much about non-invasive, although as I say, we will come back and touch on that a little bit. All right, question to the crowd. Lots of you will have started IV salbutamol, you'll have bolused it, you'll have escalated it as a continuous infusion. Some of your centres may go for aminophylline, and some of you might start with one drug, and if it doesn't seem to be working, you might swap over and start the other drug. Salbutamol, you know, is a beta-2 selective or semi-selective agonist. Aminophylline is a xanthine, which is actually what is in caffeine or coffee. My question to you all is, let's say you bolused and started salbutamol, and it doesn't matter if it worked or not or made them better. Let's say it did make them a little better. But then you do a gas and the lactate's 4, and then it's 6, and then it's 7. What would you be thinking? Why has it happened? And what will you do about it? And should you do anything about it? Someone's got to be brave and say something.
Hi, I'm Emma. I've seen it in, not so much on the infusions, but when we've got probably a bit carried away with nebulizers, and they've been on like hourly nebulizers for a while.
Yeah.
Really, the lactic acidosis that you get, that I would put down to being likely the salbutamol, and I would try and rationalize where possible, because I think sometimes we're a bit gung-ho at doing it by rote, and just putting them on like hourly, and seeing if we can reduce it, look at their fluid status as well, and obviously look at any other causes of a high lactate. But where possible, I would try and rationalize the salbutamol.
Yeah, and by rationalize, do you mean give less?
Yeah.
Great, that's a lovely answer actually. So, and yeah, it can come from NEVs rather than IV, can't it? Essentially, it's about having a lot of salbutamol in your body, and at the same time, the child's probably going to be quite tachycardic, jittery, and all the other problems that come with lots of salbutamol, like low potassium. All right, so what is happening, and should we be worried about it? Okay, this is, oops, I'm pushing the wrong computer keyboard. This is your glycolytic metabolic pathway, and that's a nice fancy picture, and I quite liked it, but actually we'll use a slightly older fashioned, simpler one. So most of you probably know that when you want to make energy, you break up glucose, it gets converted down through that chain and ends up right. And then ideally, if you've got plenty of oxygen, it then crosses over to become acetyl-CoA and it enters your Krebs cycle in the mitochondria. We are used to worrying about lactate as a sign of anaerobic metabolism, or let's say lack of oxygen. Okay, so anaerobic metabolism we get if you do a big sprint and you exceed your aerobic capacity and you're making a bit of lactate in your muscles. But obviously, clinically, the big one we worry about is sepsis, where you have inadequate oxygen delivery, and you build up lactate because you just can't convert enough of the pyruvate to go through to acetyl-CoA. So the pyruvate builds up and then it shunts sideways into lactic acid. So it's one of our biggest markers of oxygen delivery failure, and sepsis really is what we're thinking about, and it worries us, and it should worry us because it shows your metabolism is on the limit. Now that could be the case in asthma. It may be going up because, as you said, fluid status, they could be dehydrated. They might have been febrile, they'll have been breathing very hard, lots of insensible losses, and they may not have been drinking enough. That could put your lactate up a bit, although I wouldn't necessarily expect it to put it up into really high numbers unless they're in a lot of trouble cardiovascularly. More actually, so salbutamol drives glycolysis, and it drives a lot more glucose to go down into this chain. So as an adrenaline-like compound, you get loads of glucose pouring in down this pathway, and actually pyruvate can build up at the bottom simply because you've put a lot of substrate in at the top, and then some of that gets shunted off to lactate simply because you've got a huge amount of glucose coming in at the top. So if that's the case, then actually we shouldn't be quite as worried, let's say, that the lactate's gone up. It's predictable and it's understandable, and it isn't necessarily a sign of shock or poor perfusion or poor oxygen delivery necessarily. But your comment actually about checking out that theory is completely appropriate. So, the tachycardic asthmatic with a lactate going up, 100% I would give a little fluid bolus to and just see if that makes any difference. And, do a full fluid assessment. Are they weeing? Do they look dry? Do they feel thirsty? Etc., etc. So for me, it doesn't necessarily mean you have to switch to aminophylline, which is what a lot of people sometimes do. But I would take a view as a whole on, is the drug working? Are you going to be able to wean it a bit? If not, then maybe aminophylline as a tryout is going to be appropriate. The other thing to say is salbutamol, people used to give it in really high doses. If you look at some of the early papers, it can be even 5 or 10 mics per kilo per hour. I think most people's guidelines in recent years have been a max of 2 mics per kilo per hour. And actually a lot of centres have brought that down to 1. So if you can be on a half or 1 mic per kilo per hour, that's good. And if you're not, then do try and bring it down to those levels. With regards to which drug you pick, I think either is fine. If there's a history that they've been sick before and one drug worked, obviously it makes sense to go for that one drug. So that's lactate, salbutamol, and aminophylline. All right, let's say we have made the decision that this young person needs anesthesia, intubation, and mechanical invasive ventilatory support. Okay, these are the kind of steps and choices that we need to think and make and do. In broad terms, let's just think about the anesthetic approach. In broad terms, someone shout out and just say, what are the things that are going to particularly worry you about giving an anesthetic and intubating and ventilating an asthmatic?
They're going to need very high ventilatory pressures. That
may well do.
Might not, that might cause people to think maybe the tube's not in the wrong place or something, when actually you're just not able to move the chest.
Yeah. So it's worth knowing that. And often actually the patient is doing a very good job on their own, and we would be foolish to think that we can easily replicate what they were doing. So yeah, mainly very high pressures to actually move the chest, inflate their chest. Yep. What else? Risky or not risky, or somewhere in the middle?
Yeah, very risky.
Okay, why is it risky? So it might be difficult to get gas into the chest. What else is risky?
They often get gas trapping and CO2 trapping.
Yep. So we'll come back to that actually. But yeah, it can be difficult to get the gas in, but it's also very difficult to get it out, isn't it? That is the fundamental problem in asthma.
And it also depends on the choice of the agents you use to induce the anesthesia, and they might react very badly with fallen blood pressure and things, and one has to be careful in terms of use the appropriate agents. Yeah.
Yeah, great. Does anyone want to offer some drugs that they may choose to anaesthetize an asthmatic?
Some ketamine.
Ketamine.
Ketamine, great. So that's an anaesthetic agent. So anaesthesia has three parts, doesn't it? An anaesthetic agent. Actually, ketamine, it's arguable if it truly is an anaesthetic agent, but we'll say it is for our purposes. And then the other two components are an analgesic
Sedation.
and a
Analgesic and
muscle
sedation. Yeah.
Yeah. So analgesic, pretty much always fentanyl. Ketamine, as you guys said, and pretty universally in emergency scenarios these days, adult and pediatric, rocuronium. If you give a milligram per kilo, you get a good onset of intubating conditions within 60 seconds. So as good as succinylmethonium, and it's obviously non-depolarizing. There are other agents, propofol. In expert hands, it can be okay. Propofol drops your blood pressure a lot, certainly to be avoided sepsis. For an asthmatic, I just think, if it's expert hands and they want to, it's not a definite no. But I think anyone who's kind of pediatric, then in our minds, we should just have ketamine, really. And then slightly older fashioned things like thiopentone would have been the classic rapid sequence induction drug. Propofol is the more modern, modified rapid sequence induction drug. But actually ketamine, fentanyl and rock for our purposes are what we would use. The gas sevoflurane is there, and we'll come back to that again. But ketamine and sevoflurane, what properties do they have which also may make them quite useful or theoretically beneficial?
Bit of bronchodilation, I guess.
Yeah, allegedly they give a bit of bronchodilation, and again we'll come back to that. Ketamine also can make you produce a lot of secretions as well, which can in themselves be problematic. Right. At times, I think it's useful to think of all the things that could go wrong, and then that allows you to work backwards and think, how would I prepare for it? How would I minimize the risk of it happen? And also, if it does happen, then I can be a little bit more prepared with my team. This is a child where you may want to pre-allocate some roles for an emergency situation, and you might want to just think through, look, if something's gone badly wrong, what might have happened? So give me a few things. Let's say this child either desaturates heavily in a problematic way or has a cardiac arrest. What's happened? Okay, the desaturation, someone's already said breath stacking, so I'll put that on the table and we'll come back to that. Let's say they arrest. Why might they arrest? And what can you do to prevent it?
Nick, someone's mentioned something in chat about pneumothorax.
Okay, pneumothorax. I can't see the chat actually very easily. So just say things if you can. Okay, pneumothorax, well worth thinking about.
Yeah, significant drop in blood pressure, cardiac perfusion leading to arrhythmias.
Yeah, I mean, arrhythmia, possible. Your potassium might be low. You'd want to be looking for that.
And sometimes salbutamol overload, everything sort of makes the myocardium excitable, and with hypotension, hypoxia.
So let's just follow the low blood pressure. And we talked a bit about anesthetic drugs, so we've thought about that already. Why might you get sudden, very poor venous return or cardiac output in this child at point of intubation? Can anyone think why your cardiac output might suddenly drop in this child at intubation?
There's a venous return, isn't it? Yeah.
Yeah, so just tell me a bit more about that.
You're applying a lot of positive pressure.
Make you work hard. Yeah, carry on.
You're applying a lot of positive pressure to the chest, and so that will squeeze and impede your venous return.
Yeah, exactly. So actually, when an asthmatic's breathing, they're putting in a massive effort, which generates a negative pressure and sucks air into their chest, doesn't it? So their chest, although it's got trapped air and maybe under pressure, actually they're breathing in a negative pressure fashion. And then you're switching immediately over to positive pressure, and you've already said potentially very high positive pressure. So your intrathoracic pressure goes from negative, which is good for venous return, to probably very high positive, which is bad. And then we've already said the child may be a little dehydrated, intravascularly deplete. So, you know, the prevention strategy for that is consider, and to be honest, give a fluid bolus at or prior to induction. You know, fill them up a little bit, make sure they've got a slightly more reserve in terms of venous return. High pressure to oxygenate, ventilate, we've talked about. Pneumothorax, we've talked about. Now, breath stacking, you can do this to yourself, okay? Breathe all the way in, breathe out only half the way, breathe as much in as you can again, and only breathe out a tiny bit, and then breathe in as much as you can again. You get that kind of feeling of your chest wanting to explode, don't you? And you can't actually breathe in anymore. So that's sort of what breath stacking is. With each breath we put in, we don't get all of it out. And if you keep doing that, actually very quickly, you can end up hyperexpanded lungs, which you can't easily empty, massive intrathoracic pressure, and you end up not being able to ventilate. The patient starts to desaturate, and actually you'll get venous return problems again as well. And these graphs just give you a little bit of an idea of that. But if you did that breathing exercise, you'll get it as well. You can easily breath stack someone by being stressed and overexcited and getting the tube in and then bagging them very, very quickly, or even moderately quickly, to be honest. So the trick is give enough pressure to inflate the chest, and give plenty of expiratory time for the gas to come out, and just really slow yourself down. You might need to ventilate them in hard, but make sure you give them plenty of time for the gas to come out. Okay, and that will lead on to a ventilator strategy. You can breath stack them very quickly. And then really the other complication is, what if you've got the wrong diagnosis? So actually, what if it's a mediastinal mass or some other chest mass? What if actually when they got better with steroids 2 weeks ago, it was because you treated their lymphoma with steroids without realizing? And as Jatinder said, I think first wheezy episode, that's why a chest x-ray is so important. Just occasionally there'll be a child who's actually got malignancy and it's missed, and, you know, potentially partially treated with steroids. You can't see that, but if you've got a desaturated intubated child, we should use the DOPES algorithm. So displaced, is the tube actually out? Obstructed, is it blocked? So put a suction catheter down and check. P, think about pneumothorax. E, equipment. So if you're on a ventilator and they're desaturating, best to come off and use a simple bag circuit and test them out. And then S in pediatric is the stomach. If you've got a massive gas-filled stomach from being bagged at anaesthetic, and you need to empty that. I don't think this projects very well, and it's not an asthmatic, but can anyone see anything there that's a problem and tell me why?
The tube is too low on the right side.
Yeah, very good. So you can almost see it, can't you? I can't get my pointers come up, but the tube is probably at or just in the right main bronchus. That means you're not ventilating the left, so it's lost its air and it's gone white. And actually, if you look carefully, you can see a black line, which is the right lung being overinflated and herniating across. And this isn't an asthmatic, but it is something, again, if you're excited and don't want the tube to fall out and put it in too far, this just highlights why precision is important when we're looking after children. Okay, this is a bad and obvious one. This is a neonate, not an older asthmatic, but bad pneumothorax. And then this is an even worse bilateral pneumothorax. Again, not an asthmatic, but just, you know, these are severe examples. Don't expect subtle pneumothoraces to look like that. And then finally, mediastinal mass. These, again, are both extreme examples. So you need to be able to spot slightly more subtle mediastinal widening. On the right, a neonate with a huge mass, and on the screen left and on the screen right, an older person with, again, a very huge mediastinal mass. And these can cause respiratory symptoms, worse when you're lying flat, both airway and venous return issues. And if you anaesthetize and try to intubate these, you may have catastrophic loss of cardiac output, inability to ventilate, and it may be irretrievable, especially if you don't realise what the problem is because you didn't know beforehand. So mediastinal mass is to be thought about, have a chest x-ray, and, you know, treat with extreme caution. They shouldn't be anaesthetised. Right. Quick summary of what we've talked about so far. Ketamine and sevoflurane for bronchodilation we've talked about. There is this issue of histamine release making asthmatics worse. Fentanyl induction is fine. Some units will use fentanyl as their sedative agent post-intubation. It's not absolutely necessary. On our unit, we'll still use morphine for most of our asthmatics, other than the really, really, really severe ones. Morphine theoretically releases more histamine than fentanyl. And again, there is a theoretical difference between the muscle relaxants in terms of histamine release as well. Again, it's not, to be honest, usually an issue. Cuffed ETT, absolutely essential in anyone, I would say, being intubated, but certainly if you're going to need high pressures. If you do a risky, dangerous procedure and put the wrong tube in, you and the patient may heavily regret it. You don't want to have to do twice something which was difficult enough the first time or risky enough. And then ventilation, I think we've pretty much talked about this. So you want a slow rate, maximum 15, good long expiratory time, enough pressure to move the chest, but give them a good long expiratory time, you know, enough to get as much gas out as you can. This is a ventilator display. The middle line is flow. When it goes up, that's gas going in, and when it's below 0, that's gas coming out. And if you look in this patient, you don't have that flow line coming back to 0 before the next breath goes in. And again, if you look at the volume curve at the bottom, you don't get the volume back down to 0. So that's a sort of warning sign that you might be breath stacking your patient. Okay, anyone that's worked on PICU, the bit you can see at the moment on the screen is the kind of pre-intubation management. Once you're intubated on a PICU, have people seen subtly different ways of actually looking after these patients? Anyone want to give me their experience?
No more nebulizations?
Okay, so, yeah, that's part of one of the strategies. What else?
Typically in children, they, for other ventilation, they go by the age and give a big number of, you know, breaths. Whereas in asthma, you're probably going to, as you said, have a high expiratory time and low rate and enough.
Yeah, exactly.
Enough,
definitely
high
true.
Time, yeah.
Yep.
And then physio.
Very good. Very good. Okay, so I think in the UK we've got a bit of a dichotomy of how people with asthma get managed. And, you know, I think it's an evolving, changing process, but broadly units can fall, I think, into a little bit of two different camps. So the one extreme camp, let's say, is to stop all the bronchodilators, recognise they weren't working, the child had gone beyond that point. The problem actually is mucus plugging, and therefore you want to do physiotherapy. You may well use DNAs, either directly instilled or occasionally nebulized, which will certainly be less effective. The DNAs breaks up the viscid proteinaceous mucus, and then you can physio it out. And just occasionally you can do that either bronchoscopically guided to insert the DNAs or to suck it all out. But usually you can get by without bronchoscopy, to be honest. And then there's the other camp, which is giving even more of the drugs that you've already given, lots of salbutamol or aminophylline, using fentanyl instead of morphine. That's okay anyway. Some centres will start IV magnesium infusions to bring up the magnesium level on bloods. Some will do ketamine infusions, and just occasionally people even will use sevoflurane via an anaesthetic machine. I think less these days. So you've got the kind of mucus plugging physio DNA side, or you've got the give lots of drugs side. And if you've worked on a PICU, you'll have seen that done in different ways. At George's, we're very much towards the left side, but a slightly sort of moderated approach. So we do tend to give a little bit of salbutamol and ipratropium by nebs, but probably only 4 hourly, possibly 2 hourly. We'll come off and stay off IV drugs usually. We certainly wouldn't give ketamine IV or magnesium infusions IV. And then we will definitely focus on DNAs and physiotherapy and clearing out the chest. And actually, if you do that, a lot of these children who were desperately sick, you can actually turn them around, sometimes even in less than 24 hours, and get them extubated the next day or the day after. So they're the kind of two different ways of doing it that you'll see. The downside of the drug route is it often doesn't work. They can be intubated a very long time, and you start to get side effects of all of these drugs. You know, if you're on a ketamine infusion for a number of days, you'll be a little bit loopy afterwards. And again, it's just going back to that pathophysiology. The problem is mucus, so actually getting the meat out and waiting for the steroids to work for inflammation and stopping all the other drugs is often the way to go. Briefly, just a couple of things to touch on, and then we'll stop for questions. As I said, everyone these days really should be getting cuff tubes for any reason, I would say. Even the units that didn't used to like cuff tubes these days pretty much use them as a rule. And in part, that's because technology's moved on. So the tube you can see on the left here is called a micro cuff tube. The cuff is like cling film, and when it's deflated, it's pretty much like it's not there. They were made by Kimberly-Clark, who became Halyard and then became a different company name. The reason people didn't used to like cuffs is if you look at the picture on the right, the cuffs used to be quite stiff, and when they were deflated, you'd almost get these kind of blades sticking out the side, and they could cause airway trauma. The other thing is manufacturing. Different manufacturers would have the cuffs, different sizes, different places relevant to the tip. And, you know, that meant that exactly where the cuff sat, you couldn't necessarily be sure, and it could be causing more trauma as well. Final bit to talk about is functional residual capacity, which I used to kind of hate as a concept and now actually quite like. If you were to anaesthetize me now, being quite well, and you gave me 100% oxygen and then muscle relaxed me and then didn't ventilate me, how long would it take until I desaturate? Offer me some numbers. Anyone know? Deathly silence.
30 seconds to a minute. Hazarding a guess.
That's a good guess. Any other offers? So I don't know if people will be surprised or not, but you might get 7 or 8 minutes before I desaturate. So you could muscle relax me and walk off. And as long as the queue in prep's not too bad, you could get a coffee and come back. And I'll probably be okay. Don't recommend that, but you'd probably be okay. And actually, this graph helps us understand that. So, you know, normally sat here now, we're doing little breaths somewhere in the middle of our lung range. You know that if you take a deep breath, you can really fill up your lungs. And also you can actually breathe out a bit further than where you normally breathe out to. But of course, even when you've done a big breathing out, there's still some residual volume in your lungs. So, you know, if our lungs are sort of 5, 6, 7, 8, 10 litres, and you fill that with pure oxygen, then it's a bit like being a camel or an astronaut with oxygen tanks. You've got 10 litres of pure oxygen in your body. And, you know, you can do the calculations how much oxygen a healthy person's using, but your body can just sit there slowly absorbing the oxygen and you don't desaturate. And this kind of graph of breathing in and out and volumes maybe helps you understand that a little bit. That's why for any sick child, it would be important to pre-oxygenate them before you actually start the anaesthetic. But of course, they'll have a higher metabolic rate, much less expiratory and residual volume. So you should expect them to desaturate potentially quite quickly. But nonetheless, pre-oxygenating and filling up their lungs with pure oxygen is going to be very important to buy you a little bit of time. Last thing I think we'll look at before we go is just end tidal CO2. So normally it's quite a nice square wave. Your end tidal should be 0 when you're breathing in, nice fresh gas, no rebreathing CO2. And then when you start breathing out, a bit of dead space comes out, and then you plateau up to your end tidal. In asthma, your end tidal can look like this. So my question is to you, why does it look like that kind of shark fin appearance? So that's a sign of expiratory obstruction, but why? Why is that expiratory obstruction? Molly, we'll stop any minute, I promise.
No, that's all right, don't worry.
The minute someone's told me why the curve is this shape. So we'll look at this graph. For your end tidal to measure, you have to get CO2 from your lung up to the sensor, which is just outside the nose. The first bit that comes out is actually dead space, which should still be fresh gas because no CO2 would have gone into it. Then the next bit that comes out is from the large airways, and only towards the end of breathing do you get the really dirty gas full of CO2. Now, in a healthy person, that dirty gas from deep down comes out very quickly, so the curve goes up to maximum and it's largely flat, but with a very slight upslope. In asthma, it's got that curve because it takes a really long time for that dirty gas to get out. Okay, now that leads you to think, let's say the ventilator's set at 15 or 18, someone set it to 18, and I'm not happy, I come over and their gas is acidic, pH is 7.2, CO2 is 8 or 9, and I turn the ventilator down, so I change the rate from 18 to 15 or 12, and then I walk off, because that's what I do things and walk off. And then I get called back by the nurse or the SHO and say, what have you done? Your end tidal was 6, and now it's 8. We want the CO2 to go down and not up. So what just happened? And should I reverse what I did? Someone's got to say something.
I'm going by the leading question that you did the right thing.
Yes.
I think it takes time to stabilize, isn't it? You can't.
Yeah, exactly. So your blood CO2 is only going to go down, isn't it, if the CO2 can get out of your body. So if you look at that shark fin, if I sped the ventilator up, you'd cut the shark fin off sooner, wouldn't you? Which means the peak would be lower. So your end tidal would go down, but actually you're getting less CO2 out of your body. The CO2 coming out of your body is proportional to the area under that curve. Conversely, if I slow it down and you allow the ventilator to carry on letting the patient breathe out, you can imagine that shark fin will go up higher. You're getting more of the dirty gas out. Initially, your end tidal will appear to go up, but actually that's a good thing. You're probably getting more of the dirty gas out of your body. So we are going to stop there unless, and we can just see if people have got questions. It's quite a run through, isn't it?
Yeah.
You were mentioning earlier on about non-invasive sort of ventilation. At what stage would you sort of, consider that, especially once they come off the ventilator? Do they go on to that or?
Yeah, the coming off bit we can address easily. I think it just depends. It's very easy to extubate people and just automatically put them on devices. Actually, if we've done a good job, DNA'd them, physioed them at low pressure, we should just be able to extubate them onto nothing.
Yeah.
The bit about before intubation, it's very hard to say anything without leading people to do risky things. I think the only safe answer is to say that, Optiflow is easy when someone comes in. I don't think there's any particular problem with putting someone on Optiflow and see if it helps them a bit. But, it gives them oxygen, it washes out the dead space, it humidifies. It probably barely gives any pressure support at all, maybe a tiny bit, 2 or 3 equivalent. But So, you know, you can put it on and that's fine. It's another fancy way of giving oxygen, essentially, isn't it? In terms of whether you put someone on CPAP or BiPAP, I think there is just that risk of pushing very sick people way down their physiology. And if you still come to the point of intubation, they're in a much worse state than if you'd done it a few hours before. So people do it. I think you need some expert decision-making experience around it. I definitely would not sit here and advise it as standard, but I can tell you there's a number of children we get through without intubating them who are moderately severe, let's say, and we put them in an IV and we get them through, but we do that on an ITU. No, you know, we wouldn't do that anywhere else. So I think that's the kind of proviso. People do it. It's not considered completely unacceptable these days, but I just think you have to think who's doing it, who's making the decision, and what's your bailout strategy, and are you going to be in a worse position if you do it? And you know, it doesn't address that problem of mucus plugging. The minute the tube is in, we can do physio, lavage, DNAs. You can't do that with NIV. You're still going to rely on the patient coughing. And actually, are they going to cough well and clear their chest on NIV? Probably not. And I would argue you haven't really done anything to make the mucus plugging situation better. So that would be my answer, I think.
Thank you so much, everyone, for coming.